Okay, I'm gonna just move things around here. Okay, good evening. I hope everyone is doing well. It's nice to meet you all virtually. My name is Kara Mizukami Stout. I am here at University of Michigan. I also practice general endocrinology at the Ann Arbor VA as well. One more screen to move around here. Okay, so I'm excited to talk about a topic that's near and dear to my heart, which is continuous glucose monitoring in type 2 diabetes. So, sorry here, getting organized. So as a quick disclosure, I am funded by the NIH for a K-23 Career Development Award. In terms of our objectives tonight, they're pretty simple. What is continuous glucose monitoring? Why should you use these devices for your patients? And then how do you use them? So starting off, what is glucose monitoring? So as you can see, there's been dramatic advances in glucose monitoring over the past century. And in fact, blood-based glucose monitoring has only been available since the 1960s, and there's been a substantial improvements in the accuracy and transportability of these glucometers since that time. And then in 1999, the first interstitial-based glucose monitor, aka the continuous glucose monitor, was made available and approved by the FDA for type 1 diabetes. And since that time, CGM devices have really improved, not only in terms of their cost, but also their accuracy and wearability as well. So what is CGM? In short, it's a sensor that's placed in the subcutaneous fat to measure interstitial glucose values. It automatically samples and reports glucose levels every 1 to 15 minutes, and it can provide a more accurate trend of glucose levels over time. On the patient end, these glucose levels can be viewed on a smartphone or a separate reader device, and then they can not only share their data with their clinicians, but also with their friends and family as well. And this becomes really important in pediatric patients with diabetes. So what is interstitial glucose? So it's a glucose that has been diffused out of the capillary into the surrounding interstitial fluid, and it mirrors but lags behind the capillary glucose by about 15 to 20 minutes. So these devices can remain on the skin, though, for up to days at a time. So that means that you can continuously monitor glucose levels without the need for the frequent finger pokes that are needed for capillary blood glucose samples. So here's the general components of a CGM. There's this glucose sensor that sits on the skin to measure glucose values, and then it transmits these readings to a receiving device. This receiving device can either be an application on a smartphone, or it can be a separate glucometer-like screen that the patient carries with them that we call a reader. In the United States, there's 4 commercially approved manufacturers and multiple different types of CGM made by each one of these manufacturers. And these devices are essentially upgraded every 2 to 3 years. By far and away, though, in type 2 diabetes, the most commonly used devices are those that are made by Abbott, called the Abbott Freestyle Libre devices, and those that are made by Dexcom, so namely the Dexcom G6 and the Dexcom G7 devices. So when CGMs first came out, there's huge differences in the different types of CGM. And the differences in these types of CGMs are rapidly narrowing with each iterative generation of these devices. So the 2 most recent devices from Libre and from Dexcom, namely the Libre 3 and the Dexcom G7, they're pretty closely matched in terms of the location of where it's worn, the accuracy, and which populations they're approved in. They can also both alert or alarm for low and high blood sugars. And the major differences are really the duration of which substances interfere with the glucose measurements, and some slight differences in terms of the cost. Historically, Dexcom devices were the only standalone CGM devices that paired with insulin pumps. So that was kind of our go-to, particularly in type 1 diabetes. But this is really changing with the Libre 3 now having a Libre 3 Plus system, which will pair with pumps as well. So this is just a quick note about over-the-counter CGM devices. So these are actually classified as glucose biosensors and not CGM devices. And the target population is really those persons with diabetes who are not using insulin or hypoglycemic inducing medications, or those without diabetes who are interested in kind of metabolic health. And so why is this? Why are they not classified as CGMs? Well, they're really not designed to detect hypoglycemia. There's no alerts or alarms for low blood sugars. Additionally, the glucose ranges are narrower, and the devices are less accurate than their prescription counterparts. And so, for those um, um, uh, who are not at risk for hypoglycemia, they're a good option to detect glucose excursions for individual patient behavior modification and food or activity, but they're really not designed for medication dosing. Again, some caveats for the over-the-counter devices. Most notably, they're not designed nor approved for diagnosing diabetes or detecting hypoglycemia. And I wanted to make a quick distinction of the definition of hypoglycemia. So as you can see here in the teal box, hypoglycemia in the setting of diabetes is defined as a glucose of less than 70. In someone without diabetes, the probable normal range of glucoses are somewhere between 54 and 140-ish, just based on CGM studies that have been conducted. So this means that the glucose value of less than 70 without diabetes may not, that may not actually be pathologic. And so this is why we define hypoglycemia in someone without diabetes as not only the chemical hypoglycemia, but also symptoms. So symptoms specifically in the form of something called Whipple's triad, where there's symptoms in the presence of chemical hypoglycemia, and then these symptoms resolve when the blood sugar rises. So if someone has a glucose of 60, but they're not symptomatic and they're not on any medications that would cause hypoglycemia, this is really not pathologic if they don't have diabetes, right? So we discussed what CGMs are. Why would you use them? So there's multiple benefits of glucose monitoring in type 2 diabetes, and this is especially true for those patients who are using insulin. Unfortunately, this is a population that's not monitoring their glucoses very often, less than half of the time, unfortunately. So in this insulin-requiring population, self-glucose monitoring does have clear benefits, including improved glycemic control and reduced hypoglycemia. There's also increasing evidence for improvements in internal motivation and potentially weight loss and physical activity as well, that we're seeing in smaller studies. And so these are benefits that are likely in non-insulin requiring populations as well. But CGM is not yet recommended for use in this population by clinical practice guidelines yet. Unfortunately, glucose monitoring via fingerstick to obtain capillary glucose samples has many downsides. It's invasive and uncomfortable, and it also provides relatively limited information in comparison to the amount of burden it places on patients. In clinic, we rely on the hemoglobin A1C as a surrogate marker of glycemic control. This similarly has many limitations. It misses wide glucose fluctuations and hypoglycemia. It's also inaccurate in certain populations as well. So this slide shows some of the potential clinical consequences of just relying on the A1C. So both subject 1 and subject 2 have an A1C of 8. However, you can see that subject 1 has a lot of highs and a lot of lows, but the average is okay, right? But the substantial hypoglycemia burden places subject 1 at a much higher risk of life-threatening hypoglycemia than compared to subject 2, right? So are patients with type 2 diabetes then at risk for hypoglycemia? That's a question that I get asked a lot. And the short answer is yes. The risk is lower than in type 1 diabetes because there's intact glucagon, but it's still there. And so one study found that about half of patients with type 2 diabetes have a hypoglycemic event that's captured on CGM. And disturbingly, 3/4 of these are completely asymptomatic. So hypoglycemia is more common, obviously, in individuals on insulin and insulin secretagogues. So those are the populations that certainly have the highest yield for CGM. So what's the evidence for CGM in type 2 diabetes then? So there's clear benefits of CGM and insulin requiring type 2 diabetes, including those who are on basal bolus insulin regimens, as well as those who are only on basal insulin. And so one of the most prominent CGM RCTs that was done was called the MOBILE study, and it was conducted in primary care practices throughout the United States, including one site here at the University of Michigan. And the participants of this trial were patients with type 2 diabetes who were on basal insulin plus minus non-insulin therapies. And in this trial of 175 participants from diverse socioeconomic backgrounds, they were randomized to either CGM versus usual care arm. And at 8 months, there was a modest but statistically significant reduction of A1C in the CGM arm. And more importantly, the CGM arm demonstrated a substantial increase in time in range from 40 to 59%. And we'll discuss more about the significance of the time in range in later slides. But I think more telling in this particular study, they did a follow-up study where those CGM users were either continued on CGM or they were discontinued. And what they found was the initial glycemic benefits in the form of time in range gains and A1C losses were actually lost after the CGMs were discontinued. So the evidence, again, for non-insulin users is not as robust, but it is accumulating. There was a recent RCT done entitled the Immediate Trial, and this was in 116 patients with type 2 diabetes, inadequately controlled on at least one non-insulin diabetes medication. And in this two-arm trial, participants were randomized to either CGM and self-management education versus self-management education alone. The control arm also wore a blinded CGM in order to measure the primary outcome, which was the time in range at 16 weeks. And at 16 weeks, what they found is that both groups had improved glycemic control from baseline, but the CGM plus education arm was superior with a 10% increase in time in range and an adjusted 0.3% A1C reduction versus the education arm alone. And glucose monitoring satisfaction was also higher in the CGM arm. So here's a summary of the RCT and observational study data on CGM devices for type 2 diabetes thus far. So RCT data demonstrates a modest improvement in glycemic control. It reduces hypoglycemia and improves treatment satisfaction, particularly in insulin-requiring type 2 diabetes. As a result, diabetes practice guidelines, including the ADA standards of care, support the use of CGM in this population. There's likely some benefits in non-insulin requiring diabetes. The data is pretty limited at this time, and because of this, it's not routinely recommended for non-insulin users. And this difference is reflected in the coverage for CGM devices, which I'll talk a little bit about later. So, how do you use CGM then? So this is the kind of the meat of the talk here. Well, first, how do you know if CGM is right for your patients? So we discussed that insulin users are the most likely to benefit, but there are other populations that benefit as well in terms of reduction of hypoglycemia. Although it may not be covered by insurance, there may still be benefits as well in terms of lifestyle modifications for those patients not on insulin if they are really motivated. And so to determine whether or not your patient may or may not benefit, the Michigan Collaborative for Type 2 Diabetes, or MCT2D, has developed a use case guide for CGM in type 2 diabetes, which really may help you to determine whether or not your patient would benefit. And this is available on the website under the resource library. So before starting CGM, it's important to remember that CGM is a tool to help monitor glucoses. And setting realistic expectations about what a CGM can and cannot do is important for patients to be aware of the benefits and the limitations. So as a tool, CGM can monitor glucose levels, alarm for lows and highs, and demonstrate trends over time. But patients need to be able to be equipped to respond to these highs and lows, and CGM doesn't do that. And most importantly, CGM devices don't administer insulin. That's an insulin pump. And probably the most common misconception that I see in referrals to my clinic specifically for CGM. So which device? So patients will come to you often with a specific device in mind that like their brother has or their sister has or their neighbor has. and they want that specific device. In other cases, insurance companies will have a preferred device. If neither of these apply, then MCT2D has another helpful tool to help your patient choose which device for them. And this too is available in the resource library on the MCT2D website. Okay, so you've chosen a device. Now what? An important thing to note about CGM is that these devices can be covered either as a pharmacy benefit or as a durable medical equipment benefit. So if you're sending to a pharmacy, you send it in like a regular prescription, keeping in mind that all of the components will need a separate prescription. So a month's supply of sensors needs one prescription. There is one CGM device, the older Dexcom G6, that requires a transmitter to boost the signal from the sensor to the receiver, and that transmitter does need a separate prescription. And then if the patient is not using their smartphone because either it's not compatible or they don't have a smartphone, they'll need a separate receiving device called a reader, again, that will need another prescription. So if you're sending to a DME, it's kind of similar to a CPAP order. The patient must first find out which DME company is preferred by their insurer. They have to make an account with that company. The DME company then faxes over an order that must be completed by your office, and it's typically accompanied by your last note. So CGM coverage varies widely. And so MCT2D has developed two tools that can help you to discern what CGM is covered for your patient based on their plan. In general, most plans are covering for type 1 diabetes and type 2 diabetes patients who are using insulin. Coverage criteria usually requires documentation of the diagnosis, insulin use, and the need for glucose monitoring. Importantly, patients who are using Medicaid have had to be seen within the last 90 days in order for that documentation to count. Similarly, Medicare patients have to have documentation within the last 6 months, including documentation going forward in every 6 months. And then in terms of whether or not the pharmacy or DME is preferred, we typically recommend trying to send it as a pharmacy benefit first and sending it directly to the pharmacy because it's easier for the patient. DME companies often require like extra documentation. If it's not covered, or the patient says, I can't get it at the pharmacy, it's not covered, it's likely covered. It's probably covered as a DME benefit instead. And so that's when you try the DME route instead. So the use of CGM coverage dot phrases have helped in our institution to ensure that your documentation has all the necessary elements that are needed in a patient's note for CGM coverage. And this is particularly true, again, if CGM is covered as a DME benefit. We're not personally using this platform here at the University of Michigan, but many of our practices and physician organizations already enrolled in the Michigan Collaborative for Type 2 Diabetes have used Parachute Health to simplify CGM orders for DME. And they seem to really like it. They report a high success rate with using this company. Okay, so the prescription is written, and now what? How do you train these individuals on this device? And so the basic training elements are listed here. There's a variety of web-based resources on application, and to be honest, the placement of the application itself is pretty easy. They have kind of self-injecting auto-injector tools that make it really, really easy to use them and to place them. And in terms of all of the different elements of the basic training, MCT2D also has some training resources specifically for the Freestyle Libre and Dexcom CGMs that patients can kind of go through on their own at home, which is really helpful. Once the device is inserted and paired with their receiver device, it's pretty self-explanatory to use. You can see there's a reader device or a phone app that displays the real-time glucose measurement, as well as a glucose trend over the past few hours. And there's also an arrow demonstrating how fast the glucose is rising or falling. So these are some of the more advanced CGM capabilities or topics for training. which I'll go into a bit more depth here in the next few slides. And if you want more information on these more advanced topics, they're discussed in more detail on the Association of Diabetes Care and Education Specialists website. One of the most helpful features of CGM devices are the optional alerts or alarms for hypo and hyperglycemia, which are available in nearly all of the CGM systems now, except for the oldest 14-day Libre system. Similar to alerts from other types of technologies, though, these alarms can be burdensome, and alarm fatigue is a well-recognized phenomenon. And so personalizing these alarm thresholds for per patient is one way to minimize this alarm fatigue. If you recall, again, there's an arrow next to the glucose value on the CGM reader. And again, CGM devices measure interstitial glucose that lags behind capillary glucose by about 15 to 20 minutes. And so this arrow system helps the CGM wearer to determine where the blood sugar is headed in the next 20 minutes or so, based on the rate of glucose change. And so the direction of the arrow delineates if the blood sugar is rising, staying steady, or falling, and how fast this rate of change is occurring. The CGM notes and insulin input sections of the reader can also be really helpful to log food, activity, and medications, including insulin. These notes show up then in the clinician download of the CGM device here, which makes it easy to see what the glucose response is for any given behavior. So you can see this is a patient of mine logging her short and long-acting insulin doses that are circled here. And then she also made notes regarding the insulin doses and what she was doing or eating at the time to kind of give me some context of what was going on. So with a wearable, any wearable insulin or any wearable medical device, I think it's important to know that there's always going to be challenges with skin adhesion and skin irritation. These devices are sitting on the skin for up to 2 weeks at a time, so it's no surprise that skin issues are common and involve about 50% of all wearers. And so I always advise frequent site rotation and use of adhesive removal wipes as a first step. I also have provided here a few suggestions to troubleshoot adhesion challenges and lessen skin irritation as well. And then in a last-ditch effort, like the adhesive used in different CGMs is different. And so sometimes we just have to switch to a different type of CGM device. So wearing a CGM can be extremely insightful, not only for the individual wearer, but also for the clinician, especially the longer-term trends. So how do we access this data? So there's a couple ways to review patient downloads. The patients can always access their own data and send this to you as a PDF file, either in the portal or other methods of secure communication. Otherwise, each brand of CGM has their own downloading software. The Libre CGMs are downloaded via LibreView, and the Dexcom CGMs are downloaded via Dexcom Clarity. And I really find that it's easiest for every clinic to have their own practice account with each of these different platforms, and then link your account with their account to streamline the data transfer process. So how do you pull a Dexcom Clarity report? So if you create a practice Dexcom Clarity account and link it with the patient's individual Clarity account, any data they have will be sent to your practice Clarity account if they're using a smartphone as their receiving device. It kind of goes automatically up into the cloud. If they have a separate reader device, that CGM data has to be manually uploaded from their reader into the Dexcom Clarity account from their home computer before you can then pull it from their account into your practice account. Alternatively, if your practice account is not linked with their account, patients using their smartphone, specifically for Dexcom Clarity, can authorize something called a sharing code. And it's essentially like a 12-digit password that you can use directly on the Dexcom Clarity website to access their data without you needing to have a practice account. And this also is really easy, but my understanding is this process may be going away. So I still do encourage the practice Dexcom Clarity account method. So obtaining LibreView data is similar. We recommend generating a LibreView account and linking your account with the patient's account. If they're using a smartphone as a receiver, you can just type in their name in their practice account, and the data automatically transfers from the cloud into a report for you. If they are using a reader, again, they have to upload their reader at home manually into LibreView before you can pull the data. So once you have that data, you have a ton of it. So what do you do with it? So let's go through the most important elements of the CGM downloads, which are relatively similar between Dexcom and Libre. Let's start off with the statistic that is most similar to our most familiar measure of glycemic control, and that's the glucose management indicator, or GMI. And it's kind of like an estimate of the A1C based on CGM-derived mean glucoses. And the personalized goal then is similar to our A1C goals. So those healthier patients with longer lifespans would have a goal of less than 7. Those older patients with more comorbidities have a goal of less than 8%. And compared to the A1C, the GMI is more accurate in patients with conditions that affect red blood cell turnover because it's not relying on that to measure. But as an average, you still do miss the glucose variability and the glucose fluctuations. Additionally, GMI has been validated more in type 1 diabetes and may be less accurate in type 2 diabetes. So I alluded to the time and range earlier when discussing the RCTs for CGM. And so the time and range is replacing A1C as the preferred measurement of glucose control because it does account for the glucose variability. As a CGM-derived metric, it's not dependent upon the lifespan of red blood cells. And essentially, the time and range is the percentage of CGM readings that fall into a specific range between 70 and 180. That's depicted here in the green bars. Similarly, the time above range is the time with glucoses greater than 180, depicted in the yellow and orange bars. And then the time below range is the time with glucoses less than 70, depicted in red. And so the goals for time and range correspond to A1C goals. A time and range of 70% is similar to an A1C of 7%, and a time and range of 50% is similar to an A1C of 8%. So any patient with an A1C goal of less than 7, we would want a time and range of greater than 70%. Any patient with an A1C goal of less than 8%, we would want a time and range of greater than 50%. And so it's also true for hypoglycemia. In our more vulnerable patients, we would want to minimize hypoglycemia, aiming for a goal time below range of less than 1%. But in our healthier patients who can tolerate more hypoglycemia, we're okay with getting that range less than 4%. So each CGM download may be several pages long, depending on how many days of data you download. And this can get pretty overwhelming to review this much data on every single page. And so to simplify, the most important CGM metrics are viewable on the ambulatory glucose profile portion of the download. And it's essentially a summary page with the time and range, the GMI. There's also a trend line of median glucose values over a 24-hour period from midnight to midnight. And then the shading around around the darker line is the 25th and 75th and 95th percentiles of glucose values. And that gives you an idea of the variability around the median. And so just viewing this trend line can tell you a lot about how to approach treatment. So for instance, in this example, this patient is having a lot of lows between 2 a.m. and 9 a.m., corresponding to fasting hypoglycemia. And then they also have higher blood sugars throughout the day, corresponding to postprandial hyperglycemia. So they most likely need a reduction in basal insulin and a strategy to target high blood sugars after a carb load. So at the bottom of the AGP is the daily glucose profile, and this is kind of a quick way to look at the consistency of glucoses on a day-to-day basis. So for an example, this patient on the 11th, they had a late evening glucose spike, and perhaps he had a heavier carb load for dinner, but it doesn't really seem to be kind of a consistent pattern. So I don't know that I would make huge changes just based on that one day. We would talk more about what he ate for that day, right? So for the overachievers here, reviewing the daily logs from the CGM download can provide really wonderful insights into daily patient behaviors, if a patient's willing to log daily habits into the CGM. And so this patient has logged their carbohydrate intake and their insulin dosing, and this really helps to make tailored behavioral and medication recommendations. So obviously, the more you review and interpret CGM data, the easier and faster it becomes. And so I put this slide in not to stress you out, but to show you kind of a breakdown of my thought process when I look at CGM data, which can be up to 50 pages long, and that's a lot of data. How do you process it quickly? So I break it down into 6 separate steps. The first step is like, what are the patient factors that I'm going to be looking for? Medication dosing, food and activity to kind of give me some context of when I might see some postprandial spikes. What are the patient's glycemic goals? And are they more stringent or less stringent? And that gives me an idea of how much we need to move the needle. And then can we rely on the CGM data? So obviously, the more they use the CGM, the more accurate the data is. Ideally, you need at least 10 to 14 days of CGM data to have some sort of realistic estimation of what their like long-term trends are. And so the more data you have, like the more accurate it is. And then what story is the AGP telling you? As a quick overview, it gives you the time in range, it gives you the time below range, it gives you that trend line, and then this like daily glucose profile that tells you about the consistency on a day-to-day basis. And then using those, what clarification then do I need from the daily glucose logs? And, that can give me a more in-depth review of a pattern of lows and highs, and then telling me more about glucose variability. And then what changes need to be made to get the patient to their personalized goal? How do we modify adjustments in food, medications, or activity? And the first thing I always do is prioritize hypoglycemia prevention. So I think the number one question we get asked is always like, how do you bill for this? And in short, you do get credit for what you or your office does. For the initial CGM setup and training, the CPT code 95249 can be billed once during the lifetime of a device, and it's typically billed by a trained RN, PharmD, dietitian, or certified diabetes educator, or an MA in your office, often in the context of a visit outside of their clinic visit with you. In terms of billing for clinicians, you can bill for CGM interpretation using the CPT code 95251. This can be billed every 30 days by a physician or a physician extender. It doesn't require a face-to-face visit, so it can be done asynchronously. If done during the visit, you can use the modifier 25 to delineate that it was a separate service done on that day. And most insurances are covering it. We do have an occasional patient who does get stuck paying out of pocket, usually because they have a high deductible plan and their deductible hasn't been met yet. But we're seeing less of this. In terms of steps for the billing, the CGM interpretation, there are certain requirements. So first, the CGM needs to be uploaded into the EMR. So here at U of M, we upload a PDF copy of the report into the Media Manager of Epic, or MyChart, which is our EMR. There needs to be a separate written report on the analysis and interpretation of at least 72 hours worth of CGM data. And then you have to somewhere document in your note that the service of interpreting the CGM is different than the service done during the visit. And so I spent this much time on the visit and I spent this much time on interpreting the CGM. And then, of course, you bill the 9525 CPT code plus or minus the 25 modifier. At our institution, I have a sample here. We have a CGM interpretation template available as a smart phrase that our MAs prep as part of the rooming process. We also have a CGM interpretation order set that automatically adds the 95251 code to our billing. So here's the typical workflow in our clinic. The patient uploads their CGM data at home if they're using a reader, or we upload it in our clinic, or they share their data using the linked LibreView or Clarity accounts. Then our MAs, as part of the rooming process, obtain the download along with the vitals. They upload the CGM report into the EMR and penned an interpretation note. And depending on which clinic we're at, we may also get a hard copy of the report, and this really kind of depends upon clinician preference. It really works best to have, one CGM point person in the clinic, and we've used a train the trainer approach. So, we have one CGM MA person who trains like essentially all the rest of the clinics, and that's worked really well for us. So in our last few minutes, let's go over a few cases as an example of how to use CGM in your practice. So starting off here, we have a Miss S. She's a 57-year-old woman with a 20-year history of type 2 diabetes. She was referred to endocrinology for type 2 diabetes. She's on max tolerated oral or non-insulin therapies, which includes metformin, glimepiride, pioglitazone, Jardiance, and Trulicity at 1.5 milligrams weekly. She's also on Lantus 20 units nightly, and her A1C today in clinic is 8%. She's really wanting to come off of insulin. She doesn't like being on the insulin and wants to know, is there anything she can do to come off of insulin? And so the first thing that we did was discuss CGM, with the goal being to identify foods that trigger postprandial excursions to help make substitutions with lower carb alternatives. So wearing the CGM helped to identify these postprandial excursions, and she did report a pretty carb-heavy diet and was interested in lowering this carb intake. So she was we discontinued the Lantus for her preference, and I did refer her to a dietitian to discuss her food logs and her CGM data and see where there's some substitutions that could be done. There, she learned how to count net carbs. We focused on net carbs less than 100 grams per day because she is on an SGLT2 inhibitor, and I did not want her in ketosis. And so I advised her specifically to target between 70 and 100 grams of carbs per day. And on her follow-up, her A1C improved to 7%, and she was able to maintain this for the next 2 years. So circling back 2 years later, she's now 59 and on the same regimen. Her son recently got diagnosed with a very rare medical condition, and she is now caring for her adult son. And so due to this stress, she's really struggled with her diet, and on her CGM, her GMI has in fact gone up to 8.8%, and her time in range is down to 12%. And you can see on her trend line, she's just kind of high throughout the day. So we discussed a variety of options, including incorporating more dietary changes. She said realistically, that's just not going to be feasible for her right now with her lifestyle. And she actually wanted to restart the Lantus, at least temporarily. So what we did is we restarted her on a low dose of Lantus. I did refer her to social work for some counseling resources. And then as an update, I saw her not too long ago, and she's actually doing great on her diet now and was able to kind of taper off insulin herself. So case number 3, Miss H, 59-year-old woman, 20-year history of type 2 diabetes and obesity. A1C is typically in the 6 to 7% range on metformin and Ozempic. And she messaged into the portal reporting higher blood sugars on her CGM since starting a 5-day course of prednisone for an upper respiratory infection. And so even though this is a portal-based message, I was able to access her CGM. And you can see here that her GMI has gone up to 8.7%. Her target range is down to 37%. And you can see here, there's a lot of afternoon hyperglycemia and a lot of variability. And that really is kind of classic for steroid-induced hyperglycemia from prednisone. And so we discussed a couple of options. And so she elected to go ahead and start on glipizide, 5 milligrams every morning while on prednisone to cover steroid-induced hyperglycemia. Another classic medication that we use for steroid-induced hyperglycemia is NPH. And this works okay for folks who are on insulin already. She was not on insulin, so I elected to use a sulfonylurea temporarily. And she used glipizide until she finished her prednisone course, and then she stopped it. Our next case, Mr. J, 72-year-old man, 18-year history of type 2 diabetes, stage 3 CKD, CAD status post to cabbage. He's on metformin, Ozempic, Lantus, and he comes in for a routine visit. He's reporting he's doing pretty well. We downloaded his CGM in clinic, and what we see is he actually has a time in range of 36%, which is a little bit below his goal of greater than 50%, but his time below range is 8%. So this is an elderly gentleman with CKD and CAD. He is someone who I would definitely consider more vulnerable to hypoglycemia. And so someone who I'd want to get that time below range as close to 1% as possible. So when I looked at his daily trend line, what I saw was frequent times where he had fasting hypoglycemia and postprandial hyperglycemia. So we wanted to do something to reduce his Lantus, to come down, to improve that fasting hypoglycemia. And then we need something to target postprandial hyperglycemia. So we have a couple of different options. So what I elected to do for him was to reduce his Lantus by about 20%. And then he was doing well on the Ozempic dose that he was on, so we increased that, which will target postprandial hyperglycemia. We also added Jardiance for him, given his CKD. And then I'll see him back to see if he's doing better in terms of those postprandial excursions, and most importantly, reducing that hypoglycemia overnight. So case 5, and I believe this is our last case. So this is Miss C. She's a 72-year-old woman with a 20-year history of type 2 diabetes, A1C of 8.9%, obesity with a BMI of 46. She's on 30 units of Lantus, 10 units of Novolog with meals, Ozempic, 2 milligrams weekly, and metformin. She returns to you 2 days after bariatric surgery and has stopped her Ozempic 2 weeks prior to surgery. So we download her CGM. You could see, especially over the past few days, she's had some tight blood sugars in between kind of like midnight, maybe 4 to 5 a.m. So some fasting hypoglycemia. And so what we did with her is we continued off Ozempic. She just had the bariatric surgery. We can revisit that later if she needs it. I cut her Lantus by about 20%, giving that fasting hypoglycemia. And then, she just had bariatric surgery. She's going to have significant improvements in her insulin sensitivity and postprandial glucose excursion. So we stopped Novolog insulin. So with that, I'm happy to take any questions.
Dr. Mizukami Stout, there was a couple questions in the chat.
Okay.
First was, has anyone ran into issues where you freestyle Libre view onto the computer, but it can't be on a device that has VDI?
I haven't personally had that, but again, a lot of our downloads are done by our MAs at this point. So occasionally I will log into LibreView and pull a download myself, but I really haven't had any huge issues. If we do, sometimes what we'll do is we'll just have a patient generate a report and send it to us. And sometimes we're even reviewing this after the clinic visit, right? If we don't want to like waste the entire clinic visit troubleshooting CGM tech issues.
Another one, how do you bill for 95249 with having to wait until you have 72 hours of data printed? Do you bill anything at the time of training? If not, and the patient doesn't return, does that end up an unbilled service?
Yeah, so our 95249 training is done when the CGM is placed. And then typically our diabetes educators will have the patient come back at the ends of within a week or so to review the CGM data. And so that's when the 95251 is billed. And so they're kind of done on separate days. But yes, if like you didn't have 72 hours worth of data, you can't bill the 95251.
What additional questions do people have? Feel free to unmute or put them in the chat, whatever you're more comfortable with.
I put on here some additional resources, and I apologize not getting to those. Just like getting started, specific devices, guidelines. A lot of like Freestyle, Libre, and Dexcom have a lot of like patient-oriented devices. So there's not really a need to reinvent the wheel for training resources, because a lot of them are already developed and they're developed like and very user-friendly.
Here, there was a comment, they're finding it harder to get CGM replacement when like a CGM falls off. Do you have any guidance or tips for how to deal with that?
Yeah, so we see this a lot, especially in type 1 diabetes. So the first thing they have to call the company, and I think one of the first questions that they get asked is, where was the CGM placed? Right. And so what I find is, like, for instance, with the Dexcom, if I have a lot of patients who are on automated insulin delivery systems, so they're still using Dexcom G6, and that is approved on the abdomen and not the arm, but they're wearing on the arm. But if they say that they're wearing it on the arm, then that's not going to get replaced, right? And so I think just advising people really, um, you know, obviously people wear these devices wherever they wear the devices, wherever it's most comfortable for them. But in order to get it replaced, really, it has to be on an approved site, or else the company just will not do it. I think another thing to think about too is, if this is happening all the time, like we have a lot of patients who they go swimming a lot in the summer. We're a lake state. And so in the summer, that's when they'll use the extra, like they'll use skin tack, they'll use an overlay patch, like they'll use those extra types of devices to help with adhesion. Not all the time, but maybe just in high yield months.
One clarification, for the last question regarding 95249, it says in order to bill for training, you must have at least 72 hours worth of data and printout. So do you have to wait until their first download to bill for that training?
No, I'm sorry. I don't think that that's the case. I think for the 9525, let's go back. Training for the setup, right? Uh, yes, you do. I'm sorry. You're right. They do. I think that's always done by our diabetes educators. I'm rarely doing the training myself. Or if I do, I just don't really bill for the 95249. So yes, they would have to. Any other
Any,
questions?
oh, sorry.
Sorry.
While we're waiting for any remaining questions to come in, I'm going to go ahead and really briefly run through those CME slides that I had the inaccurate ones pulled up in the beginning. Apologies again for that. This is the CME. You can text this number 76471 by October 17th. This will just directly give you the link to fill out the evaluation. It will still be available even if you don't send this text by visiting this link. We're going to send you a handout tomorrow that has these details. We're offering medicine CME, nursing CE, and pharmacy CE, and dietetic CPEU for this training. And then finally, for disclosures, Dr. Lauren Oshman, who's our program director, has stocks in publicly traded companies that are listed here. And with that, I'll stop we'll do a final call for questions before we wrap up. And thank you very much, Dr. Mizukami Stout. Really appreciate you doing this today. Really informative. If you could send me the slides, that would be wonderful, and we can get them distributed to the collaborative as well.
Sure.
To the question about signing in, I know I mentioned that we do that. I ended up just doing it manually for everyone during the call versus sending you a link, so everyone is all set, and we will make sure that you get credit for attendance. All right. Hope everyone has a wonderful evening. Thank you again, Dr. Mizukami Stout.
Have a good night.
Bye, everyone.